Hello, I'm Simon Kennon, editor of Interventional Cardiology Review, and I'm here with Neil Moat, a cardiac surgeon at the Brompton Hospital and author of a recent editorial in the New England Journal of Medicine about the Partner2A trial that we are broadly going to discuss now. So I think the positive aspects of the Partner2A trial are quite well rehearsed. What do you think the negative aspects are with regard to Tavi?
I mean, I think clearly this is a very, very important trial in the stable that's come out of the partner group, and as you say, there's really a consistent message emerging in the higher risk patient population, and this was addressing patients in the top 10% of risk of people having aortic valve interventions in the USA, and Tavi is clearly equivalent and probably superior to surgery in these patients. There's still some question marks in terms of Tavi. Clearly, paravalvular regurgitation still remains an issue, significantly more common in the TAVR arm, and still a concern as we continue to go down the risk spectrum, that still remains a concern in the younger and lower risk patients. In the surgical arm, we saw really quite a low EOA, and I think it's important to recognise this in interpreting the trial, that a lot of patients were getting small stented bioprosthesis, and as in all the other trials of TAVR versus surgery, something like 50% of patients are getting a size 19 or 21 label size stented valve. Now, you can understand this in these elderly, average age is over 80, high-ish risk patients. But again, as we come down the risk profile, we get into lower risk trials, I think the surgical community would think this was not contemporary surgical practice, we needed to be implanting different types of valves, stentless valves, sutureless valves, doing root enlargements or root replacements in patients with small anatomy. So I think it's important to recognise that. The other slightly odd finding, clearly patients in the TAVR arm had shorter hospital stays, predictable. Surprisingly, the rates of rehospitalisation in the first year were equivalent between the two groups, which is slightly surprising. I would have expected it to be less in the TAVR arm, but it was equivalent.
Absolutely. And do you know, were those readmissions for cardiac reasons, or is that not specified?
It's not specified in the manuscript. I'm sure that data may emerge in time.
Yeah, okay, jolly good. All right, so that's the negative bit. So what do you think the implications of the trial are for sort of referral pathways, referral paradigms?
Well, I think, as I alluded to before, this trial really confirms, to be honest, what is already practiced, I think, in Europe, that elderly patients in their 80s with comorbidities should be treated by Tavi rather than conventional surgery, particularly if they can be treated by a transfemoral approach. I think, again, this data confirms that if you have to make holes in people's chests, be it transapical or direct aortic, in this patient population, they don't do as well as by a transfemoral approach.
Yeah, okay. So that's interesting. You're saying if they're in their 80s with comorbidities, given the the SAPIEN 3 data, do you think it would be reasonable to say anybody in their 80s should be considered for a Tavi? Not necessarily have it, but have the assessment, review the CT scan, see how straightforward it's going to be.
I think there's an argument for that. I think just a word of caution about the S3 data, the statistical design of that, where you're comparing an old historical cohort. So it's interesting data, but I think one shouldn't overinterpret that study. I think that it would be very reasonable to consider everybody over the age of 80, and that would fall very much into the trial that's going on in the UK, which is the only non-industry sponsored generic trial of Tavi versus AVR. And in that trial, anybody over the age of 80 can be randomised to one of those two treatment groups. One of the issues in terms of expanding referrals for Tavi is, in the UK anyway, an economic issue and commissioning issue. Can we afford to do that? And I think one of the key things about the UK Tavi trial, it's very heavily, a lot of the design is in terms of not just quality of life, but cost. Cost of drugs, cost of readmissions. And I think that will provide very interesting data, and one might predict the cost of Tavi is up front with the device costs, but maybe offset by a reduction in costs in the next few months.
It is an excellent trial. I guess we may start to struggle with recruitment now that the Partner2A has come out. I guess as cardiologists and cardiac surgeons, we really need to push that through in the UK and get this trial finished.
I think we do. I think probably you and I, people who are in the TAVI space, see the benefit of Tavi. It's obvious in these patients, and therefore there is sometimes a difficulty in actually enrolling people. But if we don't do it, we won't generate the economic data, and our healthcare system will not pay. So I think there's a very, very strong argument for the benefit of patients in the long term to actually finish the trial.
Yep, so lots of reasons for carrying on with it. So UK Tavi done, the Sir Tavi trial. Can you update us on that? That's the Medtronic trial.
Yes, I think that is, my understanding is that's finished recruiting.
Right.
I think the initial outcome data will probably be emerging in about a year's time. I think it will be a very interesting trial. It's going to be interesting to see how it's interpreted and analysed, because the inclusion-exclusion criteria have changed substantially during the trial, which is acceptable, but does cause some problems in terms of analysis and interpretation.
And I seem to recall they were aiming for a slightly lower risk group than Partner2A. Is that correct?
I think it probably will come out slightly lower risk, but it's still going to be. These trials are called intermediate risk trials, and I think that's fair to call them that. But we do need to remember that they're still in that top 10% of risk, in that top decile of risk. So effectively, they're still fairly high risk patients. So UK Tavi and the second Notion trial, Nordic trial, will definitely be addressing a lower risk patient group, and then true low risk trials are now starting both with S3 and core valve in the USA.
Okay, well, so final question. Do you think Tavi will be default treatment for low or low intermediate risk within the next 10 years?
I think that there will be an inevitable trend for Tavi to go into lower down the risk spectrum. How far that will go and how quickly that will go, I think is unclear. There was some excitement or concern at this meeting when Danny De Beer presented some data showing not gross but some early signs of structural valve degeneration in TAVR valves starting at about 6 years. I mean, to be honest, I think it would be a surprise to me not to have seen that, because all surgical valves, biological valves, degenerate. And what we're seeing there is a signal of early degeneration. But we also have to remember the number at risk at 6 years was about 44 patients. So I think there's been a little bit of hysteria about that data. To my mind, I think it's predictable that you start seeing that signal. But I think over the next 2 to 3 years, how much that degeneration occurs, how quickly it occurs, will influence the where we get to on that risk spectrum.
Yeah, and I guess old valves, old prostheses, that data is from Sapien XT, isn't it, and the Sapien. And I guess we weren't quite as good at sizing then, and with a lot of the patients, we just wanted to get the valve in and get out as quickly as possible. So I guess there are procedural issues.
Absolutely.
There.
So again, I really wouldn't read too much into that data. Certainly Wall Street has got itself very excited about it, apparently. But I think we should be cautious at being too concerned. And to be honest, I think, as you say, first-generation devices, perhaps slightly less than ideal implantations. It's understandable to me that you're starting to see some degeneration.
But we need to be vigilant.
Absolutely.
Okay. Neil, thank you very much.